Neil. Thank you so much for. It looks like we are not together, but we are sat across from each other. So thank you so much for inviting me down to your surgery. When I walked up, I was like, wow, it's so much bigger than I think it looks like when you take pictures of it. Um, and I think from walking around, it's like the little details. And I was saying, oh, is it a health? Do you call yourself a medical centre or a health centre? You call yourself a medical centre, but it feels like a health centre.
Yeah, it's a really interesting observation, Tara. Thank you for making time to come and see us here in Peterborough. Yeah, I mean, I would say that, Thistlemoor is built on, a lot of the hard work from my parents, my mum and dad, and their dream was to make a medical village or a health village, bringing together lots of different kind of elements. And definitely my thinking is very much evolved into thinking about kind of health, fitness, well-being, things like that. So yeah, that's a really good observation.
So let's talk about how it got commissioned. Would you be able to share a service or an innovation where you felt initially there was no spec, you created spec?
When we bought the pharmacy, we had to buy a load of buildings with it as well. And we didn't really have too much of a purpose for that building, because Thistlemoor, as we stand here today, 32,000 patients, brilliant. At that time was maybe around 14,000. And so as we, I guess, created space, we were looking at what we would do with it. And one thought we had was, we could make some apartments and staff could stay in those apartments. Now, around that time, I kind of got tapped on the shoulder by an endoscopy provider who said, "Oh, that space that you've got, could we convert that into endoscopies?" And we thought, well, yes, that fits with, our values. It fits with actually an NHS service, providing service to the community, out of the hospital, etc. And so actually, having made them into 3 apartments, we worked with the endoscopy provider, who then took on the responsibility of then converting that into an endoscopy unit. And that company then got bought out by another company called InHealth, and we've had a endoscopy provision since 2013 on the site. So it wasn't something necessarily that we potentially were thinking of doing. Having worked with an existing provider with a contract, they wanted to move from, I guess, cramped conditions elsewhere into bespoke conditions. And I think that's an interesting one, because the InHealth then served notice. So InHealth up and down the country, I think in a couple of their units, not all of them, have served notice and are, I think, focusing on other kind of business opportunities and things like that. And so we got into an interesting situation, which was that we've got an endoscopy unit that's, fit for action. Notice had been given on a contract. So actually that contract was then, going to sort of move from an NHS contract to kind of not having a contract. And so at that point, another provider kind of approached us to say, well, do you want to do this in a more collaborative way? And I think the interesting thing is, obviously, as a GP practice, some GP practices would rent out space and people would use it for all sorts of things, ultrasounds, echo, and an endoscopy unit, for example. But this was a different opportunity, which was, I guess, with the changing landscape of the NHS, could we do things more in partnership, either with the commissioner? So could we get a different type of contract that's more than just doing endoscopies? Or could we work actually directly with the hospital? And actually, by working better and more directly with the hospital, that might lead to a different relationship.
So typically then I would ask, what's the problem you're trying to solve? But it doesn't sound like it was necessarily a problem you were trying to solve. It was an opportunity that presented itself to work closer in partnership.
I guess the problem was that, as a landlord as such, we were renting space to an endoscopy unit, and that endoscopy unit had given notice. So I guess the problem that we had was that actually the space that had been used for more than a decade as an endoscopy unit could potentially not be used anymore because the people serving notice. And what they suggested was that kind of now what would be more in keeping with kind of, I guess, managing budgets and things like that would be to work directly with the hospital. So whereas before there was a contract from commissioner to InHealth and the company before them, now the arrangement was going to be with the hospital. And, actually, therefore it's a slightly different way of doing it. And so we had to work through a lot of work to think about how does the pathway work? although it sounds quite simple, it is actually quite complicated. There's lots of different kind of aspects to that. So almost, before GPs were referring directly to the unit, whereas now all activity passes to the hospital. The hospital will kind of triage that and work out which are the best patients to send out to the community for upper endoscopies, so gastroscopies, or lower, so colonoscopies. And also the unit was I guess standalone. So if, for example, a cancer or something like that was picked up, then the hospital didn't have sight of the endoscopy, the results, and things like that. Whereas with this new way of working, there was far greater ability to actually make the computer systems the same. So actually the computer system now that the unit uses is the same computer system that the hospital uses. The booking systems are also transferable as well, so that the teams can directly book from the hospital into this community-based clinic.
You said there was quite a lot of work involved. Who on your side, who are the key people assessing this opportunity, and how long did it take you from a kind of being informed that they were being served notice to kind of getting the deal done?
Well, it probably, I think the notice was served, around October, November time, and the notice therefore was for March. There was a 6-month period, I guess, where we knew. There were some kind of delicacies because obviously that unit has got staff in it, and obviously if a unit's being closed, we had to be, mindful of that kind of thing. So that made it a bit more complicated because obviously we had to respect, the process that needed to be followed from an HR perspective. But obviously in the background, we've been working with a provider, and we'd actually been thinking we're about to sort of start a new development or bring hydrotherapy, NHS dental facilities, as well as then more endoscopy space. We'd already been talking to a provider about using some of that capacity. And so when that notice was served, it allowed, I guess, more conversations about the possibilities, basically, of what could happen. So that was very helpful. But the challenge, I guess, was in a way that the commissioner's view that actually just a replacement kind of contract wouldn't be the best way of doing it, and actually kind of trying to then navigate that with the hospital and getting to the right stage, having meetings with the right kind of people and discussions. So kind of that was led by a number of people in my team from an administrative position, as well as then the new provider, Nexendo, their clinical leads and their management leads, all kind of the three parties, I guess, meeting to discuss this together. And definitely for me, whenever you start something, it's a massive period of trial, maybe a bit of error, working through pathways, getting it a bit wrong, learning from that really quickly and putting it into place. And certainly as we started the unit towards the end of May, we're getting into the position where actually, it was starting for maybe one day a week, 2 days a week, 3 days a week. And actually from September, we're hoping to go to 4 and 5 days a week. And I guess that's not just our hope as the community unit, that's from working with the hospital provider. And I think, one of the really difficult things in the NHS is that actually the budgets are difficult, right? The NHS is financially challenged and things like that. But what we've got to think about is that actually, if the activity happens in the right place, so say, for example, we can move that gastro activity out of the hospital into community setting, it also brings opportunity for the hospital, because the hospital can then strategically think, well, what am I not able to do now, and what can I then do because I've moved activity into maybe a place where it's cheaper to do, where it's better for patients, where it's close to their homes, but that also enables us to kind of generate more revenue and provide more services to the hospital. So I think this kind of has to be done in the spirit of win-win-win. We've got to understand that hospitals also have to think about their finances and balance their books and, all of that kind of stuff. But done in that way, I think it's got the best opportunity to succeed.
I want to do well. So when you're assessing opportunities, how far in the future do you want to be looking? It sounds like when you talk about from a hospital perspective, it feels like they might be able to have a good 3-year plan. But in general practice, it feels it's a little bit more, like you've got 6 years an opportunity, there is a pot of money. It feels you don't get as much runway at the moment. That may change.
Yeah, and I think for me, Tara, it's probably how we frame it, because hospitals also just have currently annual contracts. So just like general practice, we have annual contracts. And if you look at some of your income streams, some of them you think, well, I don't know, it's a bit shaky. I'm not sure in the next 3 to 5 years whether they'll continue or not. The majority of our income streams are fairly stable. So if you look back at history and you look forward to history, you can kind of predict the money and the revenue. I think what's difficult sometimes is to predict what people want from us and what they want from a service and what changes might happen nationally. And I guess that's why I try and stay really close to national policy to see what national policy is saying, see where it's going, think about where the opportunities might lie. But I would like to strike the balance. I don't believe that any national policy can, for example, really direct me at Thistlemoor as to what I should do, what things are going to work and what aren't. I think that's for us as a leadership team here, a clinical and management leadership team, in close collaboration with patients to really understand where the gaps are and where we need to either change our service or make our service better. And for me, that's the kind of creative stuff that I really love, So yeah.
Going back to service, and they said there are errors. Can you give a specific error or learning that he made or the collaborative made about this process that you would say to another party, don't do this?
So some of them is just the kind of the operations, basically. So for example, in this pathway, the hospital still does some of the activity. So the hospital does the booking, and the unit does the activity and the reporting and things like that. And obviously, for many services, I guess we want to be responsible for our booking. So say they took booking away from GP practices and it was done somewhere else centrally, it's those same kind of issues. Are the right people being put in the right slots? If you've suddenly got a number of cancellations, how do you get people booked into those slots so that you don't lose capacity? And obviously in an endoscopy unit, it's doing maybe 20 procedures a day. If you get 2 or 3 cancellations, that's like 10%, isn't it? And that's significant. So how do you have a waiting list of people that might be, ready to come into short notice? I guess simple things like sedation. What are the mechanics of it? It's a hospital-based kind of service that's happening in the community. So who should be issuing the medicines for it? Getting the right kind of licenses, the controlled drug licenses, and things like that to make sure that it's operating with good governance. Thinking through even how do the pathology samples go from the unit. So a lot of the initial problems and issues are the same kind of issues that you get when you start a service. They're the things that you think about before starting a service, but sometimes they're the real things that happen as you start a service, really. Making sure that the CQC registration is in place. And, I don't know if it was helpful, but obviously Professor Bowler came to Thistlemoor, who's the new future, the current, I think, head of primary care. So along that time, we needed a CQC inspection of the unit, and that happened in good time, which allowed the unit to open. But a lot of the uncertainty about these things makes it quite difficult sometimes when you're planning the start of a new service or a new provider.
Well, there's 3 partners in this partnership, but who is the lead?
So I would say that I'd say the 2 leads are probably the hospital, because they are effectively commissioning the pathway, and Nexendo, which is the provider. So those are the 2 partners, I guess, that are leading this project.
So when thinking about your workforce, what does kind of integration look like there?
Well, I think it's looking for opportunities. I think, what we had before was a separate unit run by InHealth and a hospital, whereas now, obviously, the closer we can work together, the better. So, for example, I think booking teams, that should be a really collaborative, the admin process of getting the right people into the right slot far enough in advance, etc. Trying to make that collaborative, so thinking about how we can share workforce, or how we can think about where booking is done and why is it only done in the hospital? Why can't the unit contribute to that as well? I think what's really interesting is, as a GP practice, having an endoscopy unit is great. It sounds flashy, it sounds great. It's great that that's happening, but I kind of when I think about it, I often see GPs who kind of want to do, let's say, 6 sessions a week, like 3 full days. They want to do something else, as well as that. And actually, why couldn't there be an opportunity for GPs to learn how to do endoscopies? Why couldn't there be an opportunity then, if we've got a unit, to share that workforce, flex that workforce? It doesn't have to just be endoscopies. Why couldn't we work with the hospital to think about GP with specialist interests? And actually, some of this, Tara, has been created through. That was probably been my vision or my thought for the last 6 to 9 months. And then all of a sudden, from being, I guess, connected, I saw in a WhatsApp group, there was something with an incredibly short deadline. So actually, there was literally a 10-day deadline to put in an expression of interest for a GP with specialist interest, thinking about working with a hospital in gastroenterology. And actually, look, we've got a really good opportunity then in this setup, haven't we? We've potentially got GPs who are interested. And actually, because we have this thought, we've been talking to our GPs, just to test it. Although I think it's a good idea. What would my colleagues think? They might think I'm bonkers, and actually many GPs said, yes, I'd love to do something like that. So for example, we had two names of GPs that work here that would be really keen on doing it. We tested it with Nexendo, with the provider. What do you think? And they said, well, yeah, this would be great. Actually, if we had some local workforce, it helps us our sustainability. And we checked it with the hospital as well. And hospital consultant Dr. Das said, yeah, I would love that, because we've got some backlogs in outpatients as well. It might not just be endoscopy, it might be other things, liver problems, things like that, taking that out into the community. So I think it's kind of, again, being in this space, looking at these opportunities and thinking how that workforce, might be combined. And definitely, if I use the pharmacy as an example, we've definitely had significant kind of benefit from, again, before we fully took on that unit, it was forever, it was Thistlemoor Medical Centre and there was Graham Young Pharmacy, and they were very separate organisations. Whereas now we've had the ability to kind of recruit people that can work across both, and obviously they're wearing quite clear hats when they're sitting in Graham Young's. They're wearing clear hats when they're sitting in the medical centre, and those roles are different. But obviously, having workforce that can move around helps people feel part of the same community. Beyond that, we've had funding from Health Education England to sort of train pharmacy technicians. And again, they move between the two. So actually, they have some general practice experience with a Thistlemoor hat on and doing Thistlemoor related work. And they have Graham Young pharmacy experience where they get trained in the pharmacy side as well. So I've seen the massive benefits from sharing workforce and workforce rotating around.
If you could sum up, it's like, what is your approach to making all of this happen? So hopefully there'll be lots of people listening to this. If they're not in a similar situation, but thinking, how do we get extra services? How do we partner that? What do you attribute your mindset to?
I think part of it is meeting people like yourself. It's listening to podcasts. It's getting inspiration. It's thinking what's happening. It's being part of policy or reading policy enough so you know what's going on. But the truth of it, the real bit of it, the bit that always makes it real, are the people. The people, I'd say, are the patients. That's why we've got a job. That's why we're here. That's what we're commissioned to do. That's why we've got money in our budgets to do things. So the patients, the people, the community, but then it's the staff, isn't it? And so for me, I think I've talked to you previously, I've been on a big learning journey in terms of health, fitness and well-being. And definitely, and I guess where that goes is personally doing a lot more exercise. So personally walking the dog every morning, an hour a day before I come into work. It's training in a facility and not just train. Old me was on a treadmill or on a cross trainer, just doing 45 minutes, and I felt I'd been to the gym. Whereas actually weight-based exercises, strength-based exercises. And so that was a personal kind of revolution for me. So then when I apply that to my people, when I apply that to my patients, what I find is actually I'm having conversations about health, fitness and well-being. Well, that's really easy as a doctor who can kind of, free up time to do the things that I do. But what does that mean for my patients? What does that mean for the people? People that are doing 50, 60 hours a week, people that are doing night shifts, how do I make it real for them? And so the thought was actually, I guess, I go to a facility, which is like a small group facility where training and diet, exercise, weight-based kind of opportunities are there to do these exercises. We've got some the COVID vaccination cabins that we've got. Actually, why don't we change those vaccination cabins into a health and fitness kind of zone like I go to? And then part of it is that instead of it just being my idea, let's test that out with our patients. How does it sound? And key patients were like, yeah, absolutely. In fact, everyone we've talked to has been like, well, why doesn't this exist? Why does the NHS not actually go, health and fitness is such a key part of it? How do we do it? And actually, what I don't think we should be doing is building a gym, because actually there's loads of gyms. People go to gyms. I think we should be using a population health management approach, picking the people that need it the most, who really need help and support with introducing exercise to them and offering them the opportunity. Knowing that some will say, I'm too busy, I can't do it, the time's not right for me. So we still need to help them in other ways. But absolutely, I mean, since that kind of opportunity has gone live in May, for patients, we've had about 30, 40 patients pass through the doors of that. But also then, what about my people? What about my staff? My staff are here, often many of them doing 40, 45 hours a week, working really hard for the NHS, admin people, doctors, nurses, etc. They don't also have time to sometimes look after themselves. But if we start introducing these concepts to them, make it free, not about money, actually go through a program. And the idea is that if we can stimulate them after 12 weeks to do it, it might make changes to their life. And in a, I guess, not a selfish way, but if my staff are happier, fitter, it might also make them more productive. It might make them more loyal, more wanting to stay with this or more, things like that. Since going live with that concept, what we've worked out is there are pathways that it works with. So actually, Cambridge and Peterborough is a pilot for Work Well, which is helping people stay in employment. And I guess kind of the idea is when people are struggling with their work, so say they're having difficult relationships with their boss, or which is very common, or they're thinking of leaving their job, or they've already left their job, then actually that's sometimes the time where probably people need to get into health and fitness more, because they're going through stress, they're going through difficulties, and then doing a small group of people that are also going through the similar problems can make a sense of community. So it's worked really well with the Work Well, and that's been commissioned now. So actually, as Work Well people go into that program, then there's budgets that come across, and that helps make it sustainable. There was an opportunity with smoking as well, and so we bid for some innovation money to actually kind of help smokers. And the idea is, instead of just offering them smoking cessation products, actually let's offer them the opportunity to get fit. Now, that comes with smoking cessation support. It comes with small group working. Rupert and Joshi would love it, because it's all about getting people together and kind of doing it together, and that makes loads of benefits. But it also combines health and fitness. It helps their lungs and things like that. So we're looking at pathway after pathway about almost, back to your commissioning question, where's the opportunity to get it commissioned? Now, I don't think very often we're moving to a future where a commissioner goes, here's a spec, can you do something? So I think it's all about us thinking about where care is not as good as it should be, and how do we fill those gaps? And then almost out of that, how do we ensure that it's commissioned? And actually I can commission that as a GP practice, I could commission it, but actually other people, public health, Work Well, councils, etc., could also commission.
I don't think that's enough, though. I do think so. You might have the need. You've got the idea, you've got the need, you've got the premises, you've got the business case. But then it's the relationships and the network. So some of this is very opportunistic. Like if you get invited to the secret dinners and the secret meals, then you're more likely. So it's great. It's up to you. Not saying it's you, but it's great if you're on that side of the table. But a lot of people aren't. A lot of people, they just... It's not always transparent. Some things are, and they are, but some things, it doesn't always feel like they are.
Yeah. I mean, I think I spend a lot of time networking, I guess, in my system and outside of my system. And I don't think from that networking, loads of opportunities that come handed on a plate. I think we are very responsive. So when we see an opportunity, that's when we grab it. So I don't think so for example, we're not a PCN test, PCN, of the 22s, despite having really close relationships with some of NHS England's leadership. We would still have to go through the same application processes and things like that. But I think it's being very attuned to opportunities, actually. And so a bit like that opportunity with the workforce, with the endoscopy unit, that as soon as that landed, it's having the kind of time, the headspace to think, wow, here is an opportunity. And so, but I do think that, a lot of the reason why I spend a lot of my time in the practice, but then also outside the practice, is to kind of really build relationships. That is true. That I think actually a lot of this comes from being able to talk to people understanding your values, understanding how you're looking to create things. And definitely for me, the neighbourhood agenda, the future, I think definitely should bring a lot more opportunities.
And the other thing I wanted to mention, kind of going back to the health and wellbeing, is that we were part of a challenge called UK Counts. So I was based on the workforce. I think 4 teams of 16 came together, and all we needed to do, it was for most K counts across 4 teams, and we could do anything to kind of generate kilometres. So we could run, walk, cycle, row.
I love being part of that challenge. And one was the sense of community, again, doing things together, being connected with loads of good people. And actually you connected me with people that I hadn't really met before. And so actually the networking, sometimes the networking can be in different mysterious ways, can't it? It could be part of a challenge that gets you networking, doesn't it? And actually, when I talked to my daughter about it, she said to me, she's 10, and she's like, "Daddy, should we go for a bike ride?" It brought me and my daughter cycling on a Monday, doing 8 kilometers or whatever it was, every Monday. And that was a lovely thing that we've continued over the summer. So, and I guess for me, what my actual kind of personality is in my thinking is introverted, but actually I kind of force myself to kind of take on these kind of opportunities. So although my inherent thoughts might be to say no or not to be part of it, actually through many years now, probably a decade and a half in NHS management, I have now my learned behavior is always to say yes, to opportunities. Why do I do these jobs? I do these jobs. I was CCG chief exec to learn. I wanted to learn what the NHS was about. I'm a place-based lead because I want to learn. What is the future? What's happening in place-based stuff? I'm a GP Federation chair because I want to learn what's scale working about. How do we... And it's not just for me. I want to learn how all of these things can make it better for patients. My patients, but also the patients of my community, also the patients of Peterborough, also the patients of Cambridge and Peterborough, and also patients of the country. Right? How do we all use all of these kind of opportunities to think about how we can prove that the NHS is not completely broken? There is a future for it. We just have to think differently. We have to frame opportunities, and we need to take that, to make things better.
I think that is a perfect place to start. If people want to get in touch with you, where should they send them?
LinkedIn, I'm quite active on LinkedIn, so that's probably my number one kind of portal at the moment. I'm a bit sluggish on emails. I'm struggling to kind of just keep up with it. So LinkedIn, lots of people drop me DMs and stuff like that. You're very welcome to do that. I'm very happy to connect with you. So that's probably the best place.
I hope you found this episode helpful, and I know that there are loads of takeaways that you would have taken from this episode, but here are my top 3. So when there's no spec, create one. If you've got an idea to create a service, rather than wait, draft it, create your own specification. Example 2, think pathway stacking. The fitness facility, which Neil talked us through, isn't just used as a fitness facility for patients, it's also used for smoking cessation, and staff can also use it. So that one facility can support multiple services and uses. Number 3, which I think is really important for our clinical colleagues, and that is to schedule networking just like clinical time. It's really, really important that you leave your consultation room. I know you're incredibly busy, but a lot of opportunities do come through networking and just meeting with people and understanding what they're doing. And sometimes it's a little bit of, like you're in the right place at the right time. So I hope that you found this helpful. Neil has been on the podcast, I think 3 times before. So we'll leave the links to his previous episodes below.